last lecture in neonatal jaundice is neonatal direct hyperbilirubinemia, or what is called neonatal cholestasis. The objective of this lecture was to define neonatal cholestasis or direct hyperbilirubinemia, explore associated clinical finding, know the causes, how we can investigate and be able to diagnose and treat biliary atresia. Now, neonatal cholestasis defined as prolonged elevation of conjugated bilirubin in neonatal period, but it usually occurs beyond the first 14 days of life. It is caused by defect in bile formation and excretion due to either hepatocyte dysfunction or from obstruction of the flow of bile through intra and extrahepatic biliary tree. It will lead to accumulation of conjugated bilirubin, bile acid, and cholesterol in the blood and in extrahepatic tissue. So there will be retention of bilirubin and bile acid, causing malabsorption of fat and fat-soluble vitamin, which include vitamin A, K, and D and E. Xanthoma due to accumulation of cholesterol. Itching also may develop due to accumulation of bile acid. Pale alcoholic stool, as seen in this picture. This is the pale alcoholic stool with dark color urine, which is usually positive for bilirubin. Also, it may be associated with progressive liver disease and biliary cirrhosis. This is an chart for color of a stool. This is an abnormal alcoholic stool, and this is normal color stool. We regard the case as direct hyperbilirubinemia when conjugated bilirubin concentration greater than 1 milligram if the total serum bilirubin is less than 5 milligram, or more than 20% of total serum bilirubin if the TSB is more than 5. It is direct hyperbilirubinemia is not neurotoxic like indirect, but it indicates a serious disease. Now, we can classify the causes of neonatal cholestasis either intrahepatic disease and extrahepatic disease. In extrahepatic disease, the most important is extrahepatic biliary atresia. In intrahepatic, it is either hepatocyte injury, which include metabolic disease, viral disease, and idiopathic neonatal hepatitis. Also, intrahepatic disease may include intrahepatic bile duct disease, and the most important is intrahepatic bile duct paucity or hypoplasia. Now, regarding the causes, we mentioned that there is an hepatocyte injury in intrahepatic disease that include infection, which include bacterial sepsis, urinary tract infection, and congenital infection, as torch, HIV, varicella, and so on. Second group in hepatocyte injury was metabolic cause, and the most important was galactosemia, tyrosinemia, alpha-1 antitrypsin, and so on. Idiopathic neonatal hepatitis, it is a disease of unknown cause. Now, the third group, intrahepatic, was toxic, which is usually seen in patients in neonatal care unit who is taking total parenteral nutrition. Also, sepsis with endotoxemia, drug-related, The other group, an intrahepatic disease that caused cholestatic jaundice, was miscellaneous, which include hypopituitarism, hypothyroidism, cystic fibrosis, chromosomal disorder like trisomy 21 Down syndrome, and neonatal hemochromatosis. Now, other group, in intrahepatic disease, we mentioned hepatocyte injury. Then the second group in intrahepatic disease is intrahepatic biliary disease or flow obstruction, which include intrahepatic biliary hypoplasia or paucity, which may be either isolated or syndromatic as part of syndrome, as in Alagille syndrome, and the progressive familial intrahepatic cholestasis. Also, we have Caroli disease, also include autosomal dominant polycystic liver disease, cyst in the liver, autosomal recessive polycystic kidney disease, cyst in the liver and kidney. Now, what is about extrahepatic bile flow obstruction or bile flow disease? The most important was biliary atresia, then choledochal cyst, neonatal sclerosing cholangitis, bile duct stenosis, insipid bile syndrome, and so on. Now, the clinical presentation of patients with cholestasis. Clinically, usually the jaundice occur after 2 weeks of age, but sometimes can be before this age and even the first day of life, as in some cases of torch infection. Usually, the color of jaundice is greenish yellowish, in contrast to jaundice of indirect hyperbilirubinemia, which is usually orange yellowish in color. It may be associated with dark color urine and light alcoholic stool. Also, there may be associated sign and symptom of fat-soluble vitamin deficiency, which may include rickets due to vitamin D deficiency, neuromuscular disease related to vitamin E deficiency, bleeding due to vitamin K deficiency, and xerophthalmia and other finding of vitamin A deficiency. Sometimes patients may complain of itching because of accumulation of bile. Also, it may be associated with hepatosplenomegaly. Also, it may be associated with sign and symptom of chronic liver disease that may include dilated vein, ascites, peripheral edema, in addition to jaundice, clogging, and so on. Bleeding, varices of portal hypertension, ascites, xanthoma, and finally it may be associated with hepatic encephalopathy. This is a picture of infant with cholestatic jaundice. You can see here the jaundice. You can see here the distended abdomen with dilated vein and peripheral swelling, and so on. This is a picture of what we see in patients with hepatic dysfunction or liver disease. All of these may be seen in patients with cholestasis if it is associated with chronic liver disease, that including encephalopathy, jaundice, epistaxis, fat malabsorption on fat-soluble vitamin deficiency, ascites, hypotonia, peripheral neuropathy, and rickets. All these, splenomegaly, hypertension, hypersplenism, all these may be seen in patients with cholestatic jaundice. Also, in clinical presentation, there is some important point in the history that may be helpful in the narrowing the differential diagnosis of neonatal cholestasis. The presence of consanguinity and family history positive for this disease that may indicate inherited disease, as in metabolic disease like galactosemia, tyrosinemia, or as in cystic fibrosis. History of neonatal death as is seen in some of the metabolic disease, antenatal fever, rash, red eye that may suggest congenital infection as torch. Neonatal infection, particularly urinary tract infection, also may causes and associated with cholestasis. Now, stool color, which is very important here, persistent alcoholic stool, pale or clay colored, suggests biliary atresia. If patient has no pale alcoholic stool or has intermittent pale stool, suggests other diagnosis that may be a viral disease, viral torch, or metabolic disease. Dark urine suggested conjugated hyperbilirubinemia, which is usually positive for bilirubin. Itching, as I mentioned previously, because of retention of bile acid. Excessive bleeding, which may indicate coagulopathy, which is either due to vitamin K deficiency or due to liver damage. Hypoglycemia, it may be commonly seen associated in patients with metabolic disease, especially galactosemia. Delay passage, if there is history of delay of passage meconium, may occur in cases of hypothyroidism and cystic fibrosis. Diarrhea may occur in infection, metabolic disease, and the progressive familial intrahepatic cholestasis. These important points in this should be focused. On examination, the jaundice, as I mentioned, of direct hyperbilirubinemia is usually greenish yellowish. We can see in the examination light alcoholic stool. We can witness it in the examination of patient. Also, it may be associated with hepatosplenomegaly and with sign of a chronic liver disease, bleeding, varices, and xanthoma and ascites, as I mentioned previously in the picture of liver disease. Sign of fat-soluble vitamin deficiency, as I mentioned. Failure to thrive, as is seen in most of the metabolic disease or congenital infection. Coarse feature of hypothyroidism and alagile, which with a special facial feature, and this is a case of congenital hypothyroidism. You can see here the coarse feature, you can see the tongue, you can see the umbilical hernia, and so on. Cataract, which is very important, may be seen in congenital infection as in this picture. Microcephaly also can be seen in congenital torch infection. Cardiac disease or cardiac murmur or sign of heart disease may be present in cases of biliary atresia or in some cases of like Alagille syndrome. Now, what is the laboratory investigation of patients with direct hyperbilirubinemia? That may include liver function test, radiological examination, and a specific test for the diagnosis. Now, liver function tests include total serum bilirubin, liver enzyme ALT and AST, include alkaline phosphatase and gamma glutamyl transpeptidase, and include PT and PTT and albumin. Regarding TSB, we have to do direct and indirect to document direct hyperbilirubinemia, which is more than 20% of total. Liver enzyme, ALT, which is specific to the liver, and AST, usually the increase of these enzymes indicate hepatocellular damage. The increase more marked in acute hepatic disease than chronic liver disease or intrahepatic or extrahepatic biliary disease. Also, we have tests for synthetic function of the liver that include serum albumin, because the albumin is synthesized in the liver, so there will be hypoalbuminemia that may indicate a severe liver disease. Also, PT and PTT, where we found prolonged PT and PTT in cases of cholestasis or in cases of the liver disease because of deficiency of vitamin K dependent factors that include factor 10, 9, 7, and 2. Also, all the coagulation factor was synthesized in the liver, except factor 8 that may be synthesized in the liver and in other places. So in severe liver disease, also there is a prolongation of PT and PTT because of deficiency of the coagulation factor. Test for excretory function that include alkaline phosphatase, which is not specific to the liver, also can be elevated in the bone disease. So another test, we have a gamma glutamyl transpeptidase, increase when there is a defect in bile excretion, as in biliary disease, hepatocellular disease, increase more in biliary. Some of the authors put cholesterol and glucose and ammonia as part of the liver function, but really the classical liver function tests include TSB direct and indirect, and liver enzyme ALT and AST with PT and PTT and alkaline phosphatase and gamma glutamyl transpeptidase. Also, we have to do complete blood count because in some cases we might find anemia, in some cases we found thrombocytopenia, as in some congenital infection. There is associated portal hypertension, may see pancytopenia, and so on. Now, regarding radiological investigation, the most important and less invasive, cheap, was abdominal ultrasound to see the size of the liver and textural echogenicity, mass, stone, choledochal cyst, gallbladder size, biliary tract, if there is acidic fluid, portal hypertension with Doppler ultrasound, also presence of other associated anomalies, especially renal anomalies. Now, what is the ultrasound finding in an infant with biliary atresia? We can see atretic gallbladder or thin wall, absence common bile duct or dilatation of the intrahepatic bile duct, hepatic parenchyma is open, inhomogeneous, triangular cord sign, which is a cranial to portal vein bifurcation, may be associated with cases of biliary atresia, choledochal cyst. So we can see a rare situation, choledochal cyst associated with biliary atresia. Also, we can see other congenital anomalies, cytosine versus polycythemia, and so on. Now, specific tests for diagnosis the cause. In addition to liver function test and ultrasound, we can do blood, urine, CSF analysis, and culture for bacterial infection or any infection. Also for viral study, serological examination for torch infection, BDRL for syphilis, urine for bilirubin, glucose reducing substance as galactose in some cases of galactosemia, red blood cell galactose 1 phosphate uridyl transferase assay in cases of galactosemia, and tandem mass spectrometry screening for some of the metabolic disease as agalactosemia and tyrosemia. This test is screening test, but When it is positive, we have to do other confirmatory tests. Serum and urine chromatography for amino acid disease, as in cases of tyrosinemia. Thyroxine and TSH in cases of hypothyroidism, sweat test for cystic fibrosis, analysis for serum level of alpha-1 antitrypsin level, and genetic study for alpha-1 antitrypsin deficiency by PIZZ Maybe need some time bone marrow examination and skin fibroblast culture in some cases, which is suspected storage disease, genetic testing for multiple disease, and one of it is allergine disease or intrahepatic familial cholestasis. Till now, the diagnosis of most cases of direct hyperbilirubinemia is done with these investigations that include liver function test, ultrasound, and other tests for metabolic and infectious disease. Except sometimes we need to do more investigation to diagnose and differentiate idiopathic neonatal hepatitis, intrahepatic bile duct paucity, biliary atresia. So we need to do hepatobiliary scintigraphy or liver biopsy. And then any patient with highly suspicious of biliary atresia and was not diagnosed should undergo exploratory laparotomy with direct cholangiograph to determine the presence and site of atresia. So after this investigation, for specific diagnosis may need hepatobiliary scintigraphy and liver biopsy, and then if we suspect biliary atresia without diagnosis, we can do exploratory laparotomy. Now, in hepatobiliary scintigraphy with technetium-99 immunodiacetic acid dye with the use of phenobarbital 5 mg per kg per day orally for 5 to 7 days before doing the scintigraphy to induce biliary excretion. Then we do the scan. In biliary atresia, there is good uptake of the dye, but no excretion, while in intrahepatic problem or hepatocyte disease, uptake is sluggish or moderate with fair excretion. Now, in biopsy, liver biopsy may provide most reliable discriminatory evidence and diagnosis. In biliary atresia, there is bile duct proliferation, bile plaque, portal or perilobular edema and fibrosis, and lobular architecture is intact, while in cases of intrahepatic disease or in neonatal hepatitis, severe diffuse hepatocellular disease, distortion of lobular architecture, inflammatory cell infiltration, and focal hepatocellular necrosis. Bile ductules show little alteration with giant cell transformation. This knowledge to know the difference between both the intrahepatic disease and biliary atresia. All patients with suspected biliary atresia and the diagnosis was not done should undergo exploratory laparotomy and direct cholangiograph to determine the presence for site of atresia. Biliary atresia, this is very important note. Biliary atresia must be identified early and differentiated from other causes of neonatal cholestasis because early surgical intervention before 2 months of age result in better prognosis and better outcome. Now, regarding clinical judgment, a patient with cholestasis and has persistently a colic stool and sonar suggests biliary atresia, Then we do the hepatobiliary scintigram, and in some cases may need biopsy. So if these support that the case mostly biliary atresia, so we take the patient to the surgery for exploratory laparotomy and direct cholangiogram, and if biliary atresia present, then we do the Kasai operation. But if the patient with cholestasis has no pale alcoholic stool or has intermittent pale alcohol, and this owner did not suggest biliary atresia, so here we do next a viral study for torch infection, for other viral disease, for metabolic disease like galactosemia, tyrosinemia. If we suspect hypothyroidism, we do hormonal study, liver scan, and all investigation of intrahepatic disease. Then we do liver biopsy. Now, treatment of direct hyperbilirubinemia or cholestasis include treatment of complication and original cause. Regarding the complication, we have the very important here, the nutrition of the patient, and there is a multiple formula with medium chain triglyceride to improve digestion of the patient, to improve the growth of the baby, because there is malabsorption of long chain triglyceride, because there is fat malabsorption. A high dose of fat soluble vitamin. Also, we have to give some micronutrients, especially zinc and calcium. Also, we have to give ursodeoxycholic acid to decrease itching and xanthoma. Also, sometimes if there is severe itching, we may need partial external biliary diversion. In some cases, that is refractory to medical treatment. Also, if there is progressive biliary cirrhosis, portal hypertension may develop, so the patient may develop esophageal varices, so we may need endoscopy for proper treatment for esophageal varices that may need banding or so on. Edema and ascites treated by salt restriction, diuretic as aldactone alone or in combination with episomide and albumin, especially if there is hypoalbuminemia. In this stage, hepatic failure may need liver transplant. Now, this is supportive treatment, and the treatment of the cause of direct hyperbilirubinemia. Accordingly, as in galactosemia, we can give him lactose-free formula. Some infection may need treatment. Surgery may be needed in cases of biliary atresia and choledochal cyst, and so on. Now we talk about biliary atresia. The incidence is 1/10,000 to 15,000 of live birth. It is more in female, involve extrahepatic biliary duct, but in some cases there is intra and extrahepatic biliary tract, and you can see here the bile duct. Here can be occur the atresia. It may be atretic, there is no passage of bile to the GIT tract. Etiology is unknown, so any patient with cholestatic jaundice, especially if it presents at the end of the first month, must be evaluated for biliary atresia, because surgery most effective before the age of 2 months. Otherwise, biliary cirrhosis and ascending cholangitis may occur, that leading to death. Infant in whom jaundice develop during the 2nd to 3rd week of life, usually there is persistently alcoholic stool and hepatomegaly. Other than these, The infant appear at the beginning healthy except for jaundice and a colic stool and hepatomegaly. But if the patient not treated later, especially after the second month of life, there is splenomegaly and progressive development of a progressive liver disease and cirrhosis and portal hypertension. And a few infants have an increased incidence of other abnormalities such as polycythemia, rotation, situs inversus, any other intra-abdominal vascular anomalies, congenital heart disease, and others. Laboratory investigation, as I mentioned previously, liver function tests demonstrate direct hyperbilirubinemia with maybe highly elevated alkaline phosphatase and gamma glutamyl transpeptidase, but it is not always highly elevated. Ultrasound finding, as I mentioned previously, hepatobiliary scintigraphy, that there will be good uptake, but there is no excretion of the dye. Liver biopsy, I mentioned the find. And finally, if we does not reach the diagnosis, exploratory laparotomy may be needed, and all patients suspected of having biliary atresia should undergo laparotomy and direct cholangiography to determine the present site of obstruction, and if biliary atresia present, so Kasai procedure, which is called hepatoportoenterostomy, should be done. Treatment and prognosis. Hepatoportoenterostomy or Kasai operation is the surgical treatment to allow for bile drainage. The operation should be done before the age of 2 months. Surgical success is judged by improvement in bile drainage and change in color of stool will recover to be normal color stool. Without surgery, patient will die because of cirrhosis before the age of 2 years. 25 to 50% of patients survive 5 years after successful Kasai procedure, but complication of the procedure may occur sometime, including progressive biliary cirrhosis and ascending cholangitis. Another treatment for most infants is liver transplant, which has 80 to 90% survival. Now we talk about idiopathic neonatal hepatitis. It is more in male with familial incidence about 20%. Also, presence with neonatal direct jaundice may be associated with growth retardation or failure to thrive, cause unknown or yet unidentified metabolic, viral, or genetic disease, but in general the cause is unknown. Normal color stool with transient colic stool, little increase in alkaline phosphatase or gamma glutamyl transpeptidase or transferase, the same. Hepatobiliary scintigraphy show the patency of bile duct. Liver biopsy show numerous giant cell lobular disorganization and necrosis with inflammation without ductular proliferation. Intrahepatic bile duct paucity or hypoplasia, it is either isolated or syndromatic, as in Alagille syndrome, or non-syndromatic isolated. Infant with Alagille syndrome may present with sign and symptom of direct hyperbilirubinemia with some of the features like cardiac valvular disease, peripheral pulmonary stenosis, butterfly vertebra or dysplastic kidney, hypercholesteremia with cutaneous xanthoma. Disease is also autosomal dominant. This knowledge about Alagille was just to know that there is a syndrome called Alagille. It is not in the exam, just to know it is not for exam. Now, differentiation of idiopathic neonatal hepatitis and biliary atresia. Here in idiopathic neonatal hepatitis, there is a familial incidence which is about 20%. Here it is unlikely to recur in the same family. Usually here no other abnormality. In biliary atresia there is a lot of abnormality like polycythemia, malrotation, situs inversus, and so more in a premature and small for gestational age have no relation. The color of the stool in idiopathic neonatal hepatitis, normal color stool with transient alcoholic. Here it may mostly persistently alcoholic stool. Liver size is less common to be massively enlarged and abnormal liver size and consistency. In hepatoscintigraphy there is a sluggish uptake and fair excretion in idiopathic neonatal hepatitis, where good uptake but no excretion. Liver biopsy there is some difference, and the final diagnosis by biliary atresia was exploratory laparotomy. Thank you very much.